Thank you very much, Hiromasa and Nicola. I was very, very impressed by this morning's talks. Thank you for having organized an excellent symposium and having added me to it. I kind of thought about what I could add to this discussion of the importance of looking at the brain at a cellular level and trying to discern a function and really apply it as a neurosurgeon to treatment. What I thought I'd do then is discuss a little bit an area of the brain that I think about a lot because we operate on that area frequently, and that is the motor thalamus and how we, by understanding the structure of the motor thalamus, can improve our treatment of tremor. So the talk itself, I'll give you, I know this is a general audience, you may have varying levels of knowledge of anatomy, so I'll talk a little bit very briefly about the motor circuit of the thalamus and basal ganglia. And then we'll focus on the motor thalamus itself, and there's really two components that we'll talk about. One is a component that you probably do not think about very often as the motor thalamus, and that is the posterior intralaminar nucleus composed of the centromedian and parafascicular complex, in particular the centromedian nucleus. And then we'll talk about the ventrolateral thalamus, which is an area that we think about more commonly as part of the motor thalamus. And we will then introduce a term, the VIM, the ventro-intermedius nucleus. And this is a term that's frequently used by neurosurgeons and neurosurgical anatomists, but not necessarily very often by neuroscientists who will tend to use the term ventrolateral thalamus. So we'll discuss that controversy a little bit and how anatomy can help us resolve this controversy. And of course, it's important because this is our main target for tremor. And finally, we'll finish by some vignettes of clinical relevance, and in particular, I'll show you how we treat tremor using a technique known as MR-guided focused ultrasound. I was at one point assigned to talk about some of our 3D atlases of the human thalamus and basal ganglia, but I thought that this will be a little bit too much for today. And if we really do have time at the very end, I'll briefly talk about them, but I'll skip it for another session. I had no conflicts to report. So the treatments we use are motivated by the disease process itself, the desperation of the disease process when medical therapies don't work, and also a certain knowledge of the anatomy and function of the target structure. And these are generally subcortical targets. And so here is a partial list of some of the targets that we use for deep brain stimulation. And many of them are actually investigational and probably will remain investigational for quite some time because we don't have adequate knowledge of the targets themselves. So there is a certain level of experimentation that goes on with deep brain stimulation because it is a relatively reversible treatment. And so people are more likely to try things out based on their concept of how the brain works, which may not necessarily be how things actually happen, especially in disease states. But the main accepted treatment is for motor disorders, and in particular, essential tremor and for Parkinson's disease. So when considering the extrapyramidal system, and in particular the motor part of the extrapyramidal system, one thinks of loops that originate in the motor and accessory motor areas and then travel through the striatum, are processed by the palatal segments and subthalamic nucleus, and finally target the thalamus. The motor thalamus is actually divided into areas that are recipients from the basal ganglia, so in this case the GPI, but also areas that receive from the cerebellum. So thus, the motor thalamus can be thought of as a pallidal thalamus and a cerebellar thalamus, and there may or may not be a certain degree of overlap between them, and that's what we will discuss. These are the classical loops, parallel processing loops that go through the thalamus, basal ganglia, and through the cerebral cortex, basal ganglia, and thalamus. And so here then is the motor loop targeting the putamen and certain parts of the GPI, and then finally the ventrolateral thalamic nuclei and back to the motor cortex. There are, of course, associational and limbic-rated loops that use separate channels within the thalamus. The motor thalamus here in this review is composed of the centromedian nucleus and then the ventrolateral nucleus and then this area called the VIM. Here, fortunately for my talk, they've actually called it the VIM, and by VIM they mean the cerebellar recipient part of the thalamus. And during this talk we will decide whether this is indeed the cerebellar recipient part of the thalamus or whether it is something more than that. So to briefly touch on the evolution of thalamic nomenclature through the ages, the fascination, the written fascination, we can only look at the written record, with the brain dates back to the Edwin Smith Papyrus, and then there's a long history summarized here by Cassel and Vasconcelos. The knowledge really accelerates of brain structure, and particularly in this case the thalamus, in the industrial and post-industrial era. And really it's in the 20th century and now, of course, in the 21st century that we've got a major acceleration of knowledge of the thalamus. It started with pretty pictures. Here, for example, I think someone showed these types of diagrams from Desjardins in D. Following these drawings, there was the availability of the Nissl stain by Franz Nissl, and he was able to actually parcellate the thalamus into 16 separate nuclei in the rabbit. He didn't publish the work for about well over 15 years, and in the meantime people took his scheme and did publish it, at the same time referring to him, but then he finally published it in 1913. But this allowed for the concept of parcellation of the thalamus into cytoarchitectonic zones. The work of the Oscar and Cecil Fote is quite important, in particular Cecil Fote-Meunier, who published on the myeloarchitecture of the monkey thalamus, and this was a seminal work that finally defined the thalamus not only according to cytoarchitecture but also myeloarchitecture. And then, of course, there was tract tracing that became available with degeneration techniques using osmium and silver, with the Marchi and Nauta Gygax type of methods, and finally axonal tract tracing, fluorescence work, and then viral assisted tracing, and then, of course, you're all very familiar with the era of MRI diffusion imaging. So here then I need to sort of refer to two schools in order to better explain the cytoarchitecture and parcellation of the thalamus. And one can be referred to as the German school, and this would be then the Fotes, and particularly Rolf Hassler, who was a student of the Fotes, and it is really his parcellation that we use in neurosurgery today, and has a specific terminology, and that's where the VIM terminology arises. There was also at the same time another school which we can refer to as the American school, and here this was perhaps led by, there were many anatomists at that time, comparative anatomists such as Elizabeth Crosby and her colleagues, and they published very influential works on comparative anatomy that included the thalamus. And then there was important work by Earl Walker, a neurosurgeon, who published a book called The Primate Thalamus, and this kind of is thought to be the origin of the American terminology. The problem, though, is summarized here by Jürgen May, and in this paper they demonstrate that if you consider different representations of the thalamus, different parcellations of the thalamus, you actually find very significant variation of representations in the human. This may in part be due to variability of brains themselves, but more likely it is due to interpretation of cytoarchitecture. So how then should we parcellate the thalamus? Should it be based on cytoarchitecture? Could it be based on chemical anatomy, or whether it's transmitters or receptors? Should it be based on gene expression? Or should we really look at afferent and efferent connectivity of the thalamus in order to provide a parcellation? And finally, how does function relate to all of this connectivity? So many of us are, many of you will be familiar with Netter's drawing with this egg-shaped thalamus with somatosensory thalamus located here, more posteriorly, and then more rostrally in the ventral thalamus. We get the motor thalamus, and then the cognitive thalamus begins more rostrally. And if we then consider thalamic nuclei, the centromedian nucleus is part of the intralaminar thalamic group, whereas the ventrolateral nuclei, or particularly the ventrolateral anterior and posterior nuclei, are part of the ventral thalamic group. So if we just briefly look at the centromedian parafascicular complex, the question may be asked, how do we actually parcellate this compared to the other thalamic nuclei? The reason this is important is it has been used as a target for surgery for many different disorders. And so the CMPF is used as a target for Tourette syndrome. It's used in some cases of Parkinson's disease. In generalized epilepsy, it's even been used for disorders of consciousness, taking people from a stuporous state and attempting to wake them up, and in chronic pain. Well, that's a very large variance in the type of disorders that are being treated. So we need to add some rationality to this by looking at the anatomy itself. So here then, in Hassler's scheme, going from rostral to caudal, we see the intralaminar system, which was thought to be part of the diffuse reticular activating kind of system related to the reticular activating system and a diffuse thalamocortical activation system. And now with anatomy, it's shown that it is more and more not so non-specific, but rather is part of a very specific system. So if we look at the posterior intralaminar nuclei, the centromedian parafascicular nuclei, we see here in this representation in human brain from the BigBrain dataset that we can analyze the centromedian and parafascicular nucleus, here shown in coronal section, but we don't really see a sharp line or a distinction. There seems to be a gradient between the parafascicular and centromedian nucleus. And when we look at our material, here shown in axial section, on a mainly crescel violet stain, it was also counterstained with calbindin, we see that we can analyze the PF and the CM, but in fact we're hard pressed to draw a very sharp line between these two structures. Looking at chemical anatomy, for example, looking at acetylcholinesterase or calbindin, once again we see that there is no sharp distinction between the centromedian and the parafascicular nucleus. Cholinergic markers are quite dense in these posterior intralaminar nuclei, whereas calbindin, these nuclei are devoid of calbindin. So we then turn to tract tracing. And so here we had injected in the squirrel monkey in the motor cortex the one fluorescence tracer and another fluorescence tracer into the sensory motor putamen, and then looked at this region of the thalamus and noticed that all of these motor related neurons providing an origin of the thalamostriatal tract and to some extent the thalamocortical tract are located in an area that is the CM, and the PF is largely, in fact, strikingly devoid of cellular labeling. So with enterograde tract tracing then, we were able to inject relatively selectively within the CM or in the PF. And when this was done, here showing the centromedian injection, going rostral to caudal in the squirrel monkey, we were able to demonstrate that the area of the striatum that is targeted by this thalamostriatal system arising from the CM is limited mainly to the sensory motor striatum, the putamen, behind the level of the anterior commissure, thus called the post-commissural putamen. On the other hand, if we were to inject the parafascicular nucleus, we would find that the labeling was mainly in the rostral striatum, in the caudate and the rostral putamen. And this is the core of the associative territory. And to some extent, there was also labeling in the nucleus accumbens, which would be the limbic territory. So PF then defines the associative limbic territory of the striatum, whereas CM, with its thalamostriatal projection, can actually define the motor striatum. We emphasize the importance of this projection by doing some electron microscopy, and here we looked at the comparison of tyrosine hydroxylase related synapses, dopaminergic synapses in the striatum, corticostriatal synapses, and thalamostriatal synapses. And it turns out that well over 30% of excitatory synapses in the striatum arise from the thalamostriatal system. So this is an important modulator of striatal function, and there's animal work suggesting that it actually modulates dopaminergic function in the striatum. So finally then, if you want to look at a review, this is one where we looked at the connectivity of the CM and PF and demonstrated that its input-output organization can be used as a defining principle for thalamic parcellation. So it's really connectivity that helps us most in parcellating this area. So when we are considering targets for movement disorders, we would then target the centromedian nucleus, whereas if we're targeting for associative disorders such as Tourette's syndrome, we would suggest targeting the parafascicular nucleus. What then is the other part of the motor thalamus, the ventrolateral thalamus, and what is the VIM, the VIM, this area that surgeons target routinely in order to relieve tremor? So the problem with these areas is that tract tracing can be performed, this high resolution tract tracing can be performed mainly in non-human primates, with less work, of course, being possible at this resolution in humans in terms of diffusion imaging. Another problem is that much of the work done by neuroscientists in primates uses the Anglo-American terminology. On the other hand, neurosurgeons are used to very standard classical atlases, such as that of Schaltenbrand and Van Buren and Burke. And these subcortical atlases use Hassler's European German terminology. So here then is an arrow that shows the VIM in Hassler's drawings. It is lateral to the centromedian nucleus, and it is anterior to the somatosensory thalamus and posterior to the part of the thalamus that receives from the GPI, which would be the ventrolateral anterior nucleus in the American terminology. I'm not going to confuse you guys by referring too much to Hassler's terminology, except for this VIM idea, which is important clinically. So here then are some atlases that show the VIM, and of course you notice that we'd be hard-pressed in defining a clear boundary. And mylar architecture, which also helps somewhat, but does not allow for a clear boundary representation. And so the Rosetta Stone, the important paper in this area, was that by Hirai and Jones. So Hirai and Jones were able to look at Hassler's terminology in human, and created their own terminology, which is not too different from the American terminology, and also looked at the monkey terminology of Olszewski. And they were able to perform some homologies. I've been sleep deprived for 3 days, between these areas, and we use this as a Rosetta Stone when we try and interpret human brain atlases. And so then, when we think of the VIM, in general, people will say that it's the VLP, the posterior part of the ventrolateral nucleus. But in fact, it is a small part of the ventrolateral posterior nucleus, as shown here. And its boundaries, we think, spread beyond the VLP itself. So we can then ask whether chemical markers would be helpful. Here then, we can stain for the standard chemical markers like acetylcholinesterase, and this was done in the work of Jones. And it is quite interesting. We see a clear delineation of the ventrolateral posterior nucleus using acetylcholinesterase, distinguishing it here on this coronal section from the ventrolateral anterior nucleus. Anne Morel, the late Anne Morel, had done a lot of work on the calcium-binding proteins, and these two can be helpful, but they're not clear distinguishing markers. They're kind of gradients. Here in our material, then, we show parvalbumin, which is quite dense in the thalamus, but again, nothing that would clearly distinguish the VLA from the VLP or the VIM. We have labeled these structures, but there's no clear boundary zone based on the chemical markers. Using calbindin, again, interesting, somewhat helpful, but not impressive. So we are then left again with the afferent-efferent solution potentially. And this solution had been proposed many years ago in this classical drawing by Pepys, who's known for the Pepys circuit. And here there's already a notion that the thalamus receives separate pallidal, cerebellar, and somatosensory inputs. The nigrothalamic had not been discovered at that time. And the work of Gérard Percheron in Paris was very important because based on degeneration studies in humans, so people with strokes or other kind of injuries, looking at the Nauta-Gygax type of method, he was able to parcellate different parts of the thalamus and call them, of the motor thalamus, and call them cerebellar sectors, pallidal sectors, or nigral sectors. And the idea was that these sectors do not overlap. This work by Anne Morel is very helpful. This summary by Anne Morel is very helpful because what it does is it defines the motor thalamus in its ventral lateral and ventral posterior components. And if we then look at the cerebellar input, she is careful in creating this kind of triangle, which suggests that, yes, indeed, the VLP or the VIM is a target for the cerebellum, and the GPI is a target. The GPI targets the ventrolateral anterior nucleus, but there is this kind of notion that there may be some overlap between these two structures. So it's a little bit counter to Gérard Percheron's argument. So the reason I'm telling you all this is that it turns out that the surgical target for tremor, whether it's essential tremor that's related to the cerebellum, or Parkinson's tremor that's more related to hyperactivity within the GPI, with a hyperpolarization going on in the thalamus and generating tremor, the target itself is the same. The surgical target we use to relieve tremor is virtually identical. So there is not a notion of targeting only the cerebellar thalamus or the pallidal thalamus. We actually target the VIM, which probably involves both elements. And this has been, this notion has been summarized by our student, now independent scientist, Christian Duval, who shows here this notion that physiologists have developed, that you get this hyperpolarization of the ventrolateral anterior nucleus, and that's where tremor is generated. But we needed the VIM involved, the VLP, and for this reason, he suggested that the reticulothalamic nucleus serves as an integrative structure and allows for the VLP to be involved in this process. So there is then this notion of an extended VIM, which goes beyond the cerebellar thalamus. Operationally, we can say that it is that area that is used by surgeons for tremor, but anatomically, it probably certainly involves predominantly the cerebellar component, but probably also involves pallidal components. So the functional VIM boundaries may include both the ventral part of the ventral posterior nucleus and a part of the VLA. More evidence for an extended VIM comes from our physiology studies in human, where people who are going through operations for tremor, in this case, we've, based on an integrated atlas, stimulated at the boundary zone between the ventral lateral nucleus and the somatosensory ventral posterior nucleus. And this is where we find that it's one of the best sites for stopping tremor, as we see here. It is also a zone that contains kinesthetic cells, so that the boundary between the VIM and the somatosensory thalamus is also not that well defined. Some kinesthetic cells, some somatosensory cells, actually invade the motor thalamus. Here then is a typical thalamotomy, and if we analyze these thalamotomies using an integrated atlas, we find that some of the most effective lesions actually involve the rostral part of the somatosensory thalamus. So the message then is that the VIM is a concept. It is not really a necessarily something that can be easily looked at only based on cytoarchitecture. You also need to integrate afferent and efferent connections and then look at surgical results. So practically speaking, in the next 5 minutes, I'll just show you an example of this type of procedure that we do using MR-guided focused ultrasound. So this is a technique where you direct over 1,000 small beams in the shape of a dome to the thalamus, and where they intersect is where heat is generated. And you can monitor this heat using the technique of MR thermometry. And you can also monitor the lesion development itself using MRI while the patient is in the machine. And finally, you can monitor the patient as heat is generated to see what is the response of tremor and to ensure that there's no side effects. So here's a patient who has a fairly severe essential tremor. So it's a tremor that's generated when assuming a posture and disappears at rest. I don't know if I can actually activate that other. It doesn't really matter. But just to show, the other part of the slide shows that he was severely disabled by this tremor. Here it is. Drinking water from a glass would be almost impossible. And he went, and this is his handwriting, trying to perform a spiral, for example, would be impossible. His drawings are shown on the right side. And this is during the procedure itself. I need to be able to accelerate this. I'm not sure. Oh, okay. It's just, no, it would be. Yeah, okay.
Well, yeah, please continue. Yes.
It's, no, it's quite a long video, so I wanted to, oops, excuse me. No, I need to be able to control it so that it goes through a little faster. Otherwise, it's quite a long video. So.
Okay.
Je pars de l'intérieur.
Oui, c'est ça.
Yeah, we can't really go through all of this in the time allotted. So it's really something that maybe there must be a trackpad on this. In any case, it shows the procedure itself with the patient who's awake going through the procedure, and we perform examinations intermittently and see that the tremor actually resolves at the end of the procedure with this type of lesion. And so this is 3 months after the surgery, and his handwriting has improved significantly. It's certainly better than mine. And also, if we see the other side, he is able to drink from a glass or from a cup. And that certainly is important for him. And here we see the difference in his spiral diagrams before the surgery on the left and after the surgery on the right side. These are the type of lesions that are generated. It is important now to see where exactly these lesions are. If we want to backtest this idea of the VIM, certainly we know that it's not in the somatosensory thalamus per se, because he did not develop any sensory side effects. But what about the pallidal thalamus or the cerebellar thalamus? So one method would be to register different atlases that have been digitized, in this case by Anne Morel. This is Anne Morel's ventrolateral nucleus analyzed in MNI space. On the right side, we see the representation by Ilinsky in his atlas. And when we do this kind of analysis, we find that the lesion itself is not limited to the ventrolateral nucleus, but actually encroaches upon the sensory thalamus, and is not limited to the ventrolateral posterior nucleus, or VIM, but also encroaches upon the ventrolateral anterior nucleus. So, and in addition, the centromedian is involved. So really, we're talking about a motor thalamus type of lesion. We could call it the extended VIM, but and of course, what Hassler had at that time was access to autopsies. So by looking at his, they had much more attention paid at that time to postmortem studies, and they were able to get a lot of information about where their radiofrequency lesions were being made at that time. Here, of course, hopefully these patients will live for a long, long time. And so we want to be able to analyze in the living brain, and that's where this atlas approach might be helpful. So when we looked at the excellent lesions, we saw that, in fact, we were extended beyond the VIM itself. And our lesions were not only in the VIM, they were centered in it, but also anterior to VIM and involved the centromedian nucleus and to some extent the ventral posterior nucleus. We've reviewed whether you can actually see the VIM in the literature. on 7 Tesla. We've done some 7 Tesla imaging ourselves, and we are not convinced ourselves that we can see it. We really need very specialized methods to examine this area. And so, as a general conclusion then, I've shown you 2 examples where an integrative approach to structure and function is essential to understanding brain organization and can serve as a ground truth for imaging and allow for design of surgical therapy. The limitations include difficulty examining postmortem tissue, limited access to postmortem tissue in some cases, difficulty in actually processing the tissue, and the need for complex axonal tract tracing studies in non-human primates. So this motivates the development of more powerful non-invasive imaging tools like the ones we'll see and we see every year at OHBM for examining structure and function and serving as a guide for therapy. But there has to be a constant crosstalk between these anatomical higher resolution methods and the type of methods that we're trying to employ in the imaging field. And so just more specifically, we've talked about the motor thalamus, the ventrolateral nucleus, and the centromedian nucleus. The VIM can be viewed as an operational concept. It's a kind of fortunate problem, because we have one terminology that we can kind of be fuzzy about. We can say, oh, that's the European terminology. That's what neurosurgeons use. And let's call it the VIM. And then, as scientists, we can go back and say, well, we've now got the ventral lateral anterior nucleus and the ventral lateral posterior nucleus. And in monkeys, we can actually define these areas much better in terms of tract tracing. And then, without necessarily sort of putting a false template onto the human brain, we can then start interpreting what the actual VIM is in human brain. So there's a bit of a nice ambiguity that goes on that allows us to think about this more philosophically and then do the experiments to prove our philosophy. So the VIM territory may extend beyond the cerebellar thalamus. So I'm going to start discouraging neurosurgeons from using this as the cerebellar thalamus or the VIM is equated in neurosurgery as that target receiving from the cerebellum. That causes confusion because we really do think that the hyperactivity of the GPI that occurs in Parkinson's as a result of dopaminergic loss is important. And so the ventrolateral anterior nucleus, which is the target of the pallidal thalamus, must have some importance in generating tremor. Histological atlases, when registered to MRI, can be useful, but the atlases themselves have significant inter-individual variability and vary with disease state. And this would have been a part of the talk if we had an hour. And so this motivates the development of improved image registration methods and, of course, development of disease-specific atlases. And diseases like Parkinson's, where there is relatively slow degeneration that goes on compared to something like a brain tumor, for example, where you get massive loss, or even Alzheimer's, where you get massive loss, I think are more amenable to creation of disease-specific atlases without having to deal with very large deformations that would then be required in other cases. But the point really is that we need these disease-specific atlases to be able to operate these or register these atlases better in Parkinson brains. Thank you. Thanks.
Thank you very much, Abbas, for a wonderful just lecture to our group. So, are there anybody who has some specific question to Abbas? Then please go to the microphone, or otherwise maybe I can pick some question from, yeah. Please.
Thank you for this very nice presentation and reminders of what a thalamus look like. Just two questions. The first one is, are you aware of the fact that the cerebellar thalamus, VLPV in the monkey, receives tons of inputs from the spinal cord as well, from proprioceptors? Yes. And then linked to that, I want to ask directly, are your patients with lesions that encroach onto what would be, of course, in MRI resolution, the mechanoreceptor thalamus losing some sensations in the hands or fingers?
Yes, both absolutely excellent questions. So with regard to the spinal cerebellar inputs, I think that's what we really are referring to. There is the kinesthetic set of responses that we get when we move the limbs and record in this part of the thalamus suggests that indeed there is a pretty significant influence from the proprioceptive system in this area. And it tends to be in the more posterior part of the ventrolateral posterior nucleus. That interface that I was talking about, I think the importance of that interface is that we do need to lesion those kinesthetic neurons. They are part of the tremor circuit. So if we think of the VIM as a target for tremor, then indeed we would think of this shell area that Jones used to refer to, that the late Edward Jones, who talked about this shell area in the monkey, and a core area that was more strictly related to touch, and this shell area more related to the kinesthetic system. That shell area, I think, is an area that we are indeed lesioning. That's the extended VIM. Yeah. So sensation that's the key factor. So we are really trying to avoid sensory loss. Because that would mean that we extended beyond that shell, the kinesthetic shell, and went into the true somatosensory touch system. And so we do get patients who have sensory loss, particularly in the edema phase, because there is an edema phase with the heat lesions that lasts about 2 weeks, and typically as edema resolves, this kind of sensory loss resolves. But for consent purposes, we tell people that they have about a 5% chance of having some kind of sensory loss with these lesions. Yeah.
Other questions? Yes, please. Could you go to microphone? Yeah.
Thank you for the wonderful talk. I'm not an expert about this totally, but as much as I know, there are many other, except for the motor function, there are also other area that the cerebellum and the basal ganglia work together, especially in the cognitive area. And I was wondering if there are other areas in the thalamus where this kind of intermixing between afferent tract that comes to play together between the basal ganglia and the cerebellum.
Yes, this is like taking me back to grad school, because in my PhD defense, one of the questions that I found very hard to answer at that time, many years ago, was exactly that. How does the cerebellum? It's a classic question. How does the cerebellum and basal ganglia actually work together? Okay, and I think that's a deep question. I think that's an important question. And of course, as you know, the cerebellum has become more and more an associative structure as well. The group in Boston, for example, Schumann and others. There are undoubtedly areas, and this would be a very interesting research topic, I think. I'm not an expert in the associative region, but there are undoubtedly associative basal ganglia elements. So that I was really talking about the motor sector of the GPI, but there are undoubtedly associative sectors of the GPI or the SNR that would then target the thalamus. And it would be quite interesting now to see that whether we have actual inputs from the associative cerebellum, kind of getting beyond the dentate nucleus, or even perhaps from the dentate nucleus, but then targeting these areas. So I think there was classical work by Asanuma and Strick and others, but I think this area deserves attention again. Sort of look at the associative and maybe even limbic thalamus, and how the basal ganglia and perhaps the cerebellum can actually work together in these areas. Yeah.
Any other question from the floor? Yes, please. Please go to the microphone.
All right. Thanks for a very lovely talk. I'm thinking about the parcellation idea that you brought up about how do we actually think about the thalamus. And in some ways, because of it's such a central structure and it's connected to so many different parts of the brain, I often wonder if it's a fool's errand to try to find the one parcellation that accurately defines all of its parts, but rather, what question are we asking? So if we care about the projection type of the thalamus, we can ask, we can parcellate it this way. If we care about the neuromodulatory receptors, we can parcellate it this other way. Whether a pluralistic parcellation will be more satisfying ultimately.
Yes, yes. I actually should have thought about putting that concept into the talk. That I think, I think it's important to find, and so I tried to find a parcellation based on our purpose, which is defining the motor thalamus, getting the best target for tremor. But depending on the purpose, you certainly could use the calcium binding proteins. They have their own, and the calcium binding protein people who've done detailed work on this have their own theories about core and shell and things like that. There are the transcription factors. RNA-seq might become quite important in terms of trying to better define these zones. But it really almost becomes a philosophical question. We have to think deeply because once we start getting this information, then what do we do with this information and how does it help us practically? How does it help us in terms of perhaps what we want to know about is function, although it may even go beyond function. It may be about development and things like that. So yeah, absolutely. I think we should introduce that idea that you can break things down in the way that we've done in a simplistic kind of way, but there has to be another level where you look at the purpose of the parcellation. Yeah, absolutely. I think that's a very nice idea. Thank you.
Any other question from the floor? Okay. Thank you very much for Abbas again for his wonderful lecture.